Good afternoon. Welcome to the latest Facebook Live event on rectal cancer treatment, research, and quality of life, hosted by the National Cancer Institute. My name is Andrea Denikoff, and I will be your moderator today. By background, I'm an oncology nurse practitioner and clinical trials expert, and my main role at the NCI is to head up the clinical trials operations of the NCI's National Clinical Trials Network, or NCTN. I've been involved in patient care and clinical research for over 30 years, and I'm passionate about wanting to help patients and their families understand cancer better, and particularly rectal cancer, I think, is a cancer we need to talk more openly about. So today, I'm pleased to be joined by two experts in the colorectal cancer field, Drs. Carmen Allegra of the National Cancer Institute and the University of Florida, and Dr. Deborah Schrag of the Dana-Farber Cancer Institute, and she's joining us from Boston, Massachusetts. So Dr. Allegra, please introduce yourself.
Thank you, Andrea. My name is Carmen Allegra. I'm Chief of Oncology at the University of Florida. I'm also a senior investigator at the National Cancer Institute, and I've been tasked with managing the NCI's national portfolio of GI cancers. I've been involved with developing and implementing new therapies for patients with GI cancers, specifically colorectal cancers, for many years.
Thank you. Dr. Schrag, please introduce yourself.
Hi, good afternoon. I'm Deb Schrag, and I'm a medical oncologist at the Dana-Farber Cancer Institute and at Harvard Medical School in Boston, Massachusetts. And I spend a considerable amount of my time treating patients with gastrointestinal cancers, including cancers of the rectum, which is a particular area of interest for me.
Thank you, Dr. Schrag. So March is Colorectal Cancer Awareness Month, and that's one reason we're discussing rectal cancer today. And while it's much less common than colon cancer, there is much to talk about regarding it, including what patients can expect in treatments, clinical trials, and research, and the myths surrounding it. I welcome you to what promises to be an interesting discussion about the present and future of rectal cancer research and treatment. In conjunction with the topics that will be discussed in our broadcast today, we encourage you to ask questions about rectal cancer research and treatment in our comments section of this video. We ask that you keep your questions and comments to today's topic of rectal cancer. If we don't get to your questions during our event, we will answer them as soon as possible in our comments. Additionally, if you have further questions, you can always contact our NCI Contact Center at 1-800-4CANCER or by visiting cancer.gov contact for live chat help. Okay, so let's get started. Dr. Allegra, can you give us an overview of what rectal cancer is and who it affects?
Sure. So let's start with a little bit of anatomy. Where is the rectum? So the intestinal tract is a very long tube, and about the last 6 feet represent the colon, but about the last 6 inches are where the rectum is. So the topic for today is just the last 6 inches or so of our entire intestinal tract. It affects somewhere around 40,000 patients a year develop rectal cancer. It is a bit more common in African Americans. There is clearly an age-related occurrence of rectal cancer. The older you get, the higher the incidence. The peak, or the average, is somewhere in the mid-60s or so, but there is about a 10% occurrence rate in individuals under the age of 50. There's been a very disturbing trend in recent years, and that is an increasing incidence of rectal cancer in young individuals under the age of 50. We don't exactly know why this is occurring, but it is a clear trend. We need to understand a lot better and watch much more carefully for the occurrence of these cancers. There's a number of risk factors that we should think about as individuals. It increases our risk of having colon or rectal cancer. One is family history. If your parents or a sibling had colon cancer or rectal cancer that could increase your risk, especially if those individuals were relatively young when their cancer occurred. Smoking is an important risk factor. Obesity, another risk factor. Some individuals have inflammatory bowel disease, and this is another major risk factor for the development of bowel cancer. And the final one is polyps. So these are probably the initiation of every cancer of the colon and rectum starts as a polyp. And that's why having a screening colonoscopy is so important, because the gastroenterologists can remove these polyps and hopefully prevent the occurrence of cancer. We'll talk a little bit more about colonoscopy in a bit.
Okay. Anything you wanted to add to that, Dr. Schrag?
No, those are really the key risk factors, but I think the good news is there's actually a lot that you can do to decrease your personal risk of colorectal cancer. As though we needed another reason to exercise and to have a healthy diet. We know all those things, but minimizing obesity, not smoking, those really can help decrease the risk of rectal cancer.
Thank you. So how about tell us a little bit more about the symptoms and how we diagnose colorectal cancer, and what are the standard treatments and what patients might expect?
Yeah. So probably the most important thing for individuals to keep in mind is to just know your body. The most important thing is to notice a change, and certainly a change in bowel habits would be very important. The occurrence of diarrhea, constipation, if you start to lose weight unintentionally, especially a lot of weight, that would be a tip-off that there's something that's not right. Blood is another frequent symptom of having large bowel cancer, and that could be in the form of either bright red blood, or sometimes the stool just gets very dark, black, tarry looking stool, and that's another indication that something just isn't right. If you have enough bleeding, you could become anemic, and fatigue can be a big problem. Not a little bit of fatigue like we all have, but a lot of fatigue. That should tip you off that there's something problematic. How do we diagnose it? Well, certainly if you see a change in your bowel habits, you would visit with your doctor, describe those, and what the doctor would do is he would do some standard blood tests to see if you did have anemia or see if there was any other abnormalities in your blood. Most of the time that will be relatively normal, but the doctor could also look to see if there's any blood in your stool by doing some simple tests. And this may be blood that you would not see, but with using very sensitive tests, you could find it. When you do find it, you would certainly want to go on to get the gold standard, which is a colonoscopy. And even if you didn't find it, if you were of age, 50 years old or more, the doctor would probably want you to have your colonoscopy. And in general, colonoscopies will diagnose any rectal or colon cancer, and that's considered the gold standard of diagnosis. Once a diagnosis of some abnormality is made, the doctor would take a biopsy, examine it under a microscope, make the diagnosis of a cancer, and then we would proceed to manage that cancer. And very importantly, if the cancer is early, it is very curable. And that's why it's so important to make sure that you watch your body. If there are changes, talk to your doctor, get your colonoscopy, get the diagnosis, have your problem taken care of. Much easier to take care of early versus late.
Thank you. And Dr. Schrag, do you want to talk about what are some of the standard treatments for rectal cancer?
Sure. So the good news is that because more and more people are engaging in the kind of screening behaviors that Dr. Allegra was speaking about, we're catching more and more rectal cancer at the early stages where the cure rates are high. And those are rectal cancers at stages 1, 2, and 3. Really early cancers, rectal cancer stage 1, usually can be treated successfully simply with surgery and nothing further. But the intermediate cancers, the stage 2 and 3 rectal cancers, which we often call locally advanced, so they've spread into the muscle of the wall of the rectum and maybe a little bit further, but they haven't spread outside of the local rectum. Those cancers can be cured, but the cure is complicated and it's quite arduous. It's a lot for patients to undergo. The outcomes are great, but it's a lot to go through. And it's a lot to go through because it involves 3 different strategies: surgery, chemotherapy, and radiation. There are different ways of sequencing them and organizing them, but overall it's a treatment which takes a good 6 months to get through. People can work during that time, people are not completely incapacitated, people are home. Other than the surgery, all these treatments can be given while people are outpatients, but it's certainly disruptive to people engaging in all their usual activities. People feel tired and have a good number of side effects. But again, with application of all 3 of those approaches, surgery, radiation, and chemotherapy, cure rates are high and indeed are achieved in the vast majority of patients.
Great, thank you so much. And I just want to interject that for those of you just joining us, we're talking about rectal cancer treatment and research in honor of Colorectal Cancer Awareness Month. And you can ask us questions in the comments, and we'll get to you as soon as we can at the end. So back to our topic. While we've made great strides to talk more openly about other cancers, like prostate cancer, breast cancer, colon cancer, there's still patients that feel uncomfortable talking about colorectal cancer, and specifically rectal cancer, in the social setting. Can you tell us both a bit more about your experience in dealing with your patients and how to help them cope with a diagnosis and feel more comfortable just openly talking about it? Dr. Allegra?
Yeah, it is a tough area. It's certainly an area that people do not choose to discuss openly and freely. But as we were saying earlier, and as Dr. Schrag was pointing out, early diagnosis is critical to cure. So even though it's an uncomfortable topic, it is critical to recognize a change, have a discussion with your doctor, and have the problem dealt with if there is a problem to deal with. Dr. Schrag?
Yeah, so go ahead, Dr. Denikoff.
Yeah, I just wanted to understand, Dr. Schrag, your input as well. I certainly know that there's many things people are very open about, talking about breast cancer and other cancers. There's marches for them, but you just don't hear people talking about rectal cancer. How have your patients coped with it?
You know, my patients joke, all those pink ribbons when you get on the airplane and the pink ribbon on the napkin, the brown ribbon just doesn't quite work as well. So, I mean, I think we find that, yes, these topics are uncomfortable. You know, any cancer that's in any reproductive organ or in the pelvis or has anything to do with going to the bathroom is just an inherently uncomfortable topic. It feels private. But, you know, we do have more work to do to try to destigmatize it. But the more we do talk about it, we have office workers who engage in get your colonoscopy parties, you know, where everybody decides to get their colonoscopy the same week and drink the same week and joke about being up all night in the toilet the night before the colonoscopy. You know, a little bit of humor seems to go a long way. Families that have their colonoscopies together try to schedule them on the same day and then take the day off and take the afternoon off and go do something more fun. You know, I think openness and humor And also, I think we have to do a good job featuring the people whose lives have actually been saved by having had appropriate screening and early detection. And those folks are really the best communicators. They're really able to spread the message in their workplaces and through their social networks.
Thank you. I think humor is a great way to do that, and I'm going to take your advice for my next colonoscopy. So another thing, actually, I had a grandmother who had colon cancer, not rectal, but she needed a colostomy after her colon cancer surgery, and she had a really hard time dealing with it at age 80. So what are your thoughts about commenting on that for the patients and public listening? How do people deal with that, and how common are they after treatment?
I'll start, but I'll let Dr. Schrag also give her thoughts. Because of the advances in technologies, and especially if we're talking about early disease, colostomy is not all that common. So even for patients with rectal cancer, about 75% do not need a colostomy.
Great.
The cancer is at a point in the rectum where the surgeon can cut it out and then rejoin the inside. So you don't need a colostomy. So I think the advances that are being made, and Dr. Schrag will talk about one of her studies, is trying to diminish the amount of intervention, in her case radiation, but in other cases surgery. The occurrence or the need for colostomies is actually decreasing. And one of the goals going forward is to so much improve our systemic therapies like chemotherapy that we may not need surgery in some cases, or be able to limit the surgery. Not right now, but that's something for the future. That's where we're going.
Right. That's great. That's great. Well, I do have to say one positive thing about my grandmother. She was able to, it was a temporary colostomy, and then she was able to have it removed and reconnected. She needed
and that's
healing
often
time.
The case.
And she was very happy about that.
Everybody.
She went on to live a very successful life, to 102.
There you go.
So there was a successful one. So, and Dr. Schrag, I think Dr. Allegra had a great segue into some of the improvements being made. And I know you're the principal investigator of a really important study that's being done in NCI's National Clinical Trials Network that's trying to really improve the long-term quality of life for patients. So if you want to talk about that study, I think that would be a great time to do so.
So I definitely want to talk about the study, which I'm passionate about, as you know, but I don't want to leave your grandmother in the dust. So I want to talk about your grandmother, and your grandmother reminds me of a particular patient of mine who I want to tell you the story about her. And I really think I tell you her story because we do research differently now, and it's a good segue into the trial where patients are not the objects or simply who the research is being done on. We are engaging patients. Patients are partnering with us. Patients are pushing the envelope because they don't want to put up with the unpleasantness of treatment. They want a say in the matter. So the patient I'm thinking of is a woman who I took care of when I practiced at Memorial Sloan Kettering in New York, and she owned a very high-end Madison Avenue boutique. She was an extremely fashionable woman, and she had a perfect figure, which she was very proud of, but she also had a low-lying rectal cancer, and she needed an ostomy. And she looked at the appliances, and she looked at the devices, and she said, they're not appropriate coverings and fabrics and material, and they're not appropriate undergarments, and I'm calling my designers, and I'm having appropriate materials designed. And she designed such a line that makes it really much easier for people who have ostomies to look good and appear in fashion magazines and do their jobs. Now, is it hard to be a bikini model with an ostomy? Yeah, that's hard. But when your grandmother probably had an ostomy, I'm guessing that the company Spanx hadn't yet hit the scene. So there are lots of improvements that make it easier for people to have good quality of life if they do need an ostomy. And at the same time, the rates of ostomy have plummeted because we have better imaging, better surgical technique, and more surgical detection. So fewer people need them, but those people who need them are better able to cope. And that's because we're doing a better job engaging patients. Sounds like we missed your grandmother, but in general, we're doing a better job at engaging patients in our research studies. As for the study that we're doing now in partnership with your leadership, together with the National Cancer Institute, and this study, I'm proud to say, is being done all across the United States and Canada, all the way to Hawaii and Alaska. This study is trying to see whether we can simplify rectal cancer treatment and make it less difficult, and see if we can more strategically use the treatments that we know can work. So ordinarily, as I said earlier, we give patients radiation, an operation, and then chemotherapy. And in this study, we're asking the question whether we can achieve similarly good outcomes and high cure rates by giving some patients chemotherapy, then taking pictures with an MRI to see if patients are responding to that chemotherapy. And if they are, we can then skip the radiation, take them straight to the operating room, and avoid the radiation. For those whose tumors are not melting to chemotherapy, they still have a chance to get the radiation. So in a sense, we're trying to streamline and simplify and omit radiation for patients who don't need it because their cancers are responding beautifully to chemotherapy, but make sure we give it to patients who have tumors that don't respond as well. What's the advantage of this? Well, patients are able to get through treatments more quickly. They're able to achieve treatments that we hope they're more likely to respond to and may have less side effects. This is what we hope, but we don't know it. And the only way we're going to learn this is if we do this clinical trial that requires courageous patients to enter into to help us answer this question. Patients who've gone in this clinical trials are incredible heroes. We're incredibly grateful to them. They have received either the standard treatment or this new approach, but we're going to learn from each and every single person's contribution, and it's going to enable us to treat the next generation of patients more strategically.
Thank you. I have to endorse your trial. It's extremely important, and I know the patient advocacy community especially is very excited about this trial, having a goal to improve the quality of life and the quantity of life at the same time.
The patient advocacy community is incredible, and patients in this trial, they're telling us how they're feeling. They report in on their cell phones, and they tell us what their symptoms are and how bad each week is their diarrhea, their fatigue, their nausea. So, you know, this trial is going to have incredible information, and we'll be able to share it with patients. You know, one of the things that is very clear to us is that it may be, at the end of the day, that there are two different ways to treat rectal cancer that each achieve very good outcomes. And in that case, we can give patients a choice. And it may be that there are different ways to achieve the same cure rates, but they have different side effect profiles. And that will be a great win for patients because it'll help them make a decision to choose the treatment that is a better fit for their lifestyle.
Right, I agree. And I think it's great that your study is including patient-reported outcomes and quality of life questionnaires so that patients will have that information as well. So we do have another trial at the NCI that's complementing your trial. Maybe Dr. Allegra could comment about that.
Sure. There is another very important national trial. It's known affectionately as the TNT trial, which stands for Total Neoadjuvant Therapy. But in essence, what this trial does is it changes the order in which we intervene with the three different modalities. Chemotherapy first, radiation, and surgery is the last modality.
And this one is for patients who aren't eligible for Dr. Schrag's study.
Correct. So patients with rectal cancer are eligible for the vast majority for either Dr. Schrag's study, the Prospect study, or if not, the TNT study. So almost everybody with rectal cancer would be eligible for one or the other of these studies. And the hope with the TNT study is that we could improve the radiation that we're delivering and the chemotherapy. And the hope one day is that we'll do such a good job with chemotherapy and maybe radiation that we may not need that surgery, or we could limit the amount of surgery that we have to have.
So really personalize it to each person.
Correct.
That would be great. That would be great. Any other trials that Dr. Allegra or Dr. Schrag you want to mention here, or important research? Because we'll be moving on to questions in a few minutes.
The only other trial I would want to mention is a trial that involves both patients with rectal cancer as well as colon cancer. And this is a trial for patients who have metastatic disease, advanced disease.
So it's spread to other organs.
It's spread beyond where it started, either in the colon or the rectum, maybe to the liver, to the lungs. And about 20% of the time, when patients have that spread, their tumor has a very particular genetic abnormality. And it seems to respond very well to immunotherapies. So we're now studying immunotherapies in this population in patients with metastatic disease. We're also studying it in patients with colon cancer with the intermediate stages of disease that we've been talking about in patients with rectal cancer. This seems to be very powerful therapy. Although the studies are ongoing, we have great hopes for immunotherapy in this population.
Wow, that's very exciting. That's very exciting. So a big part of all this conversation is about the quality of life after treatment and how we're doing that. And I think we wanted to discuss, Dr. Schrag touched on it, but the sphincter sparing surgery and how we can do less treatment to improve quality of life. Did you want to talk about that, Dr. Schrag?
Sure, I'd be happy to. So most patients with rectal cancer are able to spare the rectal sphincter, and that's the muscle that we all use to hold it. So when you got to go, it's that hold it muscle. And most operations preserve that muscle, and then patients do not need a permanent ostomy. Some people may need a temporary one, but they will not need a permanent ostomy. But it can take a while to recover from surgery. Bowel habits aren't immediate right away, particularly if people have had radiation as well. It can take a while to recover. People will have to move their bowels more frequently, sometimes get up at night, sometimes have some diarrhea or have some new food sensitivities. So, one of the goals of our study and really all clinical trials is to try to get patients through these treatments and achieve those high cure rates without interrupting people's lifestyles too much. And collecting these questionnaires and having patients tell us exactly what their symptom levels are really helps us figure out strategies that work and strategies that don't. And that includes studying things like diet and foods to avoid, different lifestyle habits and patterns that can help people achieve better outcomes. We make a big distinction between quality of life effects that happen during treatment while people are actually going through radiation, chemotherapy, surgery, and those that are long lasting, that are still present, for example, 6 to 12 months later. The good news is more and more research shows that patients who get through treatment and are successfully cured, by the time we look 6 to 12 months later, adaptation levels are really high, and most people's quality of life is back to their pre-treatment baseline. So that's the good news.
That's very good news. So I think there's a common thread here today, is that so much of the research that we've been doing over the years is really catching the cancer earlier, treating it earlier, less toxic, and patients living longer and better quality of life. And I think that's very exciting for patients to hear about, and hopefully we'll bring them to their doctors sooner. So let's also talk about the future of research. So we're doing these trials now, but what's next? What are some future things that you want to tell us last bit before we go on to questions?
Well, we talked a little bit about immunotherapy, and we know that's very powerful.
And it's in the news a lot. How does it apply here?
It's in the news. So, as I said, maybe 1 out of 5 patients with colorectal cancer would benefit from immunotherapy currently. The trend, though, for the future is to try to figure out how to apply immunotherapy to the other 80%.
Right.
So that's a major area of research. And the other exciting area is we know that many rectal cancers and colon cancers have specific genetic defects, mutations in their genes. And we now have an arsenal of therapies that we could apply specifically to patients whose cancers have a very particular mutation. And the hope is that that will be greatly beneficial for patients with cancer. And we'll find that out as we move forward over time.
Great. So that's also in the news a lot as well.
Yes.
People having their tumors getting genetically tested for mutations. So that's a big part of the future research as well.
It is, and I would say that most patients with colorectal cancer have their tumors genetically profiled these days.
That's becoming standard.
It's becoming very common. Yes.
Is that what you're seeing in your institution as well, Dr. Schrag?
Yeah, so I would say for patients with advanced cancer, so patients with colorectal cancer that is already spread, getting the tumor profiled with genomic sequencing is really standard of care. And it helps us figure out both which drugs are likely to work. Those genomic profiles give us 3 important pieces of information. They help us figure out which drugs that are available, that are approved by the FDA, should be given in what order and are likely to work. It also helps us figure out which drugs that are approved by the FDA are not likely to work and are going to waste the patient's time and produce side effects with no benefit. So we can use patients' time wisely. And the third thing that those profiles are helpful for are helping us to figure out which clinical trials are going to be most strategic, most likely to provide benefit. So that's why genomic testing is really become almost a standard for patients with advanced disease. For patients with early stage colorectal cancer, most of the time it's not necessary. Cure rates are so high as it is, treatments are really standard, so we don't have to do the elaborate genomic sequencing because the treatments are quite standard. The protocols are more simple, and pathologists around the country are well able to characterize and evaluate these tumors. Sometimes people worry that insurance companies don't cover the genomic sequencing for early stage cancers. They should be reassured and not concerned because it's usually not needed. Whereas for advanced disease, there really has started to be very compelling evidence of benefit.
Thank you for clarifying that. I think that's really important because I hear that talked about a lot, and I think that's very helpful for everyone to understand.
Yeah.
So before we go on to questions, is there any final comments, Dr. Schrag or Dr. Leiker, you wanted to point out?
Not right now.
I would say one thing that we think about in rectal cancer, if you have an early stage rectal cancer, it's really important for your team of physicians to help figure out what the stage is and then what the right treatment is for you. Too little treatment is not good and can compromise your outcomes, but too much treatment is also not good, and you might need to experience side effects that you could avoid. So the key with rectal cancer is careful diagnosis and involvement of a team of experts that includes an experienced surgeon, a radiation oncologist, a medical oncologist at a hospital with a pathologist who's familiar with treating these cancers. So rectal cancer is treated not by one physician, but by teams of physicians who work together. And if you're trying to figure out where you want to get your care, you want to look for groups of physicians and nurse practitioners that take a team-based approach.
Well, I'm glad you added that nurse in there, because we're a key part of the team.
You are. We know that.
So I agree. I agree. We need a team approach. Thank you. So we do have some questions coming in. So we'll go to the questions. And the first one is, what is the biggest factor to reduce risk of rectal cancer? Is it exercise or fiber or some sort of healthy combination? What are your thoughts, Dr. Allegra?
Well, it is a combination. Stop smoking.
Not a pill.
Stop drinking too much. Obesity is a major risk factor. So obviously weight loss or getting a good BMI would be very, very critical. And I think vigilance is absolutely essential. You know your body. If there are changes, speak up. Talk to your doctor about it.
Right. That's good advice. Okay, we've got another question coming in. What new immunotherapy is ready after 12 infusions of standard treatment for metastatic rectal cancer? And what, if any, advanced techniques are available to cure it or being worked on? Maybe we'll give this one to you, Dr. Schrag.
So this is one of the incredible challenges. I wish immunotherapy was ready, but immunotherapy is not ready for colorectal cancer. Immunotherapy is ready and part of standard of care for lung cancer, for melanoma, and more recently stomach cancer has been added, liver cancer is getting added, but for colorectal cancer it's not. It seems as though immunotherapy works, as Dr. Allegra mentioned previously, for a small subset of colorectal cancers that express a particular genomic feature. Those that have something known as microsatellite instability, or those that have what we call a high tumor mutation burden. Unfortunately, that is the vast minority of colorectal cancers. So for other colorectal cancers, the way we use immunotherapy is in combination with other treatments on a clinical trial. Just giving immunotherapy off the shelf, we've learned the hard way, doesn't work. And immunotherapy is pretty toxic and it's got a lot of side effects. So we really don't want to expose people to it unless it's likely to benefit them. So on its own, it doesn't work. So what we need to do is explore novel combinations. I think, what do you do if you're facing this decision right now? Step number one, get your tumor genomically sequenced. And if you have microsatellite instability or high tumor mutational burden, which will be obvious from the report and your physicians will know that, then receiving immunotherapy or participating in a specific protocol for that group is a priority. If those findings aren't present, then participating in a clinical trial is still a great idea, but standard immunotherapy is almost certainly not going to be a good use of your time, and prioritizing other strategies makes a lot more sense.
Thank you, Dr. Schrag. I think that was really, really helpful.
Yeah.
Another question just came in. Does the gut microbiome hypothesis, as in colon cancer, apply to rectal cancer? And I'm sure this is a well-educated question being put in, so you might, one of you might want to, who takes this, describe what the question means, too.
So I could give this a crack. So the microbiome, all of us in our gut have many, many bacteria of all sorts. That's considered the microbiome. And it's been found that people with cancer, colon cancer and rectal cancer, have very specific sorts of bacteria that exude certain chemicals, which are thought to be somehow involved with the process of developing that cancer. It's probably, so the question was, is that hypothesis true for rectal as it is in colon? And I'm not absolutely certain, but I would say yes, because the biology of rectal cancer and colon cancer are indistinguishable. So whatever is causing one, likely to be contributing to the other. And that is a very important and hot area of investigation.
So more area of research. So another question that's just been asked is, we're hearing more and more about younger people being diagnosed with a gastrocancer. I'm not sure exactly what they mean, maybe gastric cancer. Will they consider changing the minimum age to lower than 50 eventually for colonoscopies? So maybe they do mean gastrointestinal cancers.
Yeah, I'm sure this is referring to the increasing incidence of rectal cancer in individuals under the age of 50. There has been a lot of discussion about changing the guidelines, but from a public health perspective, the incidence of rectal cancer in individuals under the age of 50 is still relatively small. It's increasing in number, but the absolute number is still very small. And it's probably not cost effective to screen everybody at under age 50
with the colonoscopies,
which is that's what you'd have to do for that population.
But I assume at least in younger people they could at least have their stools checked for anything.
Absolutely, and especially if you have a family history or some of the risk factors that we've been talking about, obesity, smoking, a low fiber diet.
Right. Okay, so there's another question. Is there any suspicion, hypothesis for the increase of processed foods leading to an increased risk of rectal cancer over the past several years? Dr. Schrag, you want to take this one?
I'm sorry, an increase in the what leading?
Increase of eating processed foods that might be leading to an increased risk of rectal cancer.
Yes, absolutely. So in particular, there is a long-standing hypothesis, and there's actually some very good evidence from studies that have followed cohorts of individuals over many years that show that diets that are high in processed meats, particularly smoked meats, cured meats, hot dogs, hamburgers, things with lots of preservatives, nitrates, individuals with diets that have lots of those ingredients in them do face a higher risk of colorectal cancer. So, we have good refrigeration, there's lots of healthy, fresh food choices available, so I think part of a healthy diet is avoiding frequent consumption of highly processed foods. There is also an association with red meat in general, which is why all national nutritional recommendations limit the consumption of red meat to no more than a couple of servings per week. Yeah, there's very good evidence for that. Does that mean we all need to run out and be vegetarians? No, it doesn't. But is eating McDonald's every day a good idea? No, it's not.
Right. So back to that point earlier where we said everything in combination, from exercise to good diet to healthy choices. So thank you. So we have time for one last question. Someone wants to know where clinical trials might be located near them and how would they find out. And I'll take that question since that's near and dear to my heart, and I'm passionate about people thinking about clinical trials as one of their many treatment options. And if you're in an area that isn't near a major hospital center, academic center, one easy thing to do that the NCI has, we have a contact number, 1-800-4-CANCER, so you can call and speak to someone, or we also have a chat possibility if you're more of an online person at trials.cancer.gov, and you can put in the type of cancer you have, such as rectal or colorectal, and do a trial search and look for, you can put in your zip code and do a search. Another option is if you are close to major medical centers, they typically have a call center and you can call them directly. But if you want to do some looking first, the internet is a good option, or so is our NCI Contact Center. I'm guessing, Dr. Schrag, your center probably has a hub of for patients in your area in Boston to find as an example.
Yeah, absolutely. So, I also have to make a plug for patients who've been on clinical trials. So there are a number of colorectal cancer advocacy groups, and many of those folks have been through treatment, often on a clinical trial, and they are really amazing repositories for advice about how to navigate the system. But the other advice that I think is just, very general and very basic, that I think is helpful for both patients with the new diagnosis as well as the family members and friends who want to support them, is when you go see a rectal cancer treatment team, whether it's the surgeon, the medical oncologist, or the radiation oncologist, you want to leave that appointment with 2 questions answered. And the first question is, doctors, how would you recommend treating my cancer with a standard of care approach, not in an investigational clinical trial? And the second question is, how would you recommend treating my cancer with a research clinical trial? And is there one that is right for me? And you want to get the answer to both of those questions, and then really have an informed discussion about the risks, benefits, and trade-offs of the standard treatment approach or the clinical trial.
Thank you, Dr. Schrag. I think that was really important, and as part of our NCI's National Clinical Trials Network, we have a network of over 2,000 investigators all across the country and in every state. So hopefully patients have access to places that are near them where they have that option to ask their doctor about trials they have locally. So thank you so much to both of you. Yes, Dr. Schrag?
So I just want to say to the folks who are listening in, leaders like Dr. Allegra and Dana-Farber have really done a tremendous job making it possible for patients all over the country to get access to state-of-the-art treatment. So I happen to work at a major cancer center in a small city in New England, but clinical trials are available to patients in all 50 states. They're available to patients who live in rural communities, far away from medical cancer centers, through community-based cancer centers. So the National Clinical Trial Network really has an incredible scope and reach, and they're very dedicated physicians nationwide who are committed to this program, which is led by the National Cancer Institute. So it's really a crown jewel in the NIH, the public. This is a public program. These are our taxpayer dollars at work, and when people draw a short straw and get cancer, they can benefit from this. So it's something I think that we as a country should be very proud of.
Well, thank you, Dr. Schrag. That was great, and thank you for spending time with us from out of your busy practice, as well as you, Dr. Allegra. And I think Dr. Schrag ended on a really great note. Would you like to end on anything specific, Dr. Allegra?
Just echo your thank you to Dr. Schrag. We greatly appreciate that. And a hello to my colleagues at University of Florida. Go Gators!
Okay, well, really, thank you both. And for our viewers, I'd like to remind you that this video will appear on the National Cancer Institute Facebook website and page, and also be on your YouTube channel as well. So if you have family members, patient advocates, and others that might have interest, you can share that with them, as well as information about our cancer trial information webpage, trials.cancer.gov. And if you have any final questions that were not answered today, please send them and we'll be sure to get back to you. So we really want to thank everyone for tuning in to the NCI's latest social media event, and we look forward to our next one hosted by the National Cancer Institute. Thanks to all, and have a great day.
Thank you.